Okay, thanks for joining us. So just a quick overview. The lab has been open since 1996. It kind of came with the new Shriners Hospital building that they built at that time. And I am kind of original equipment. I've been with the laboratory since then, kind of a long time now. And Amy has been there almost as long, like 18 years, right? As old as Jack is. Yeah, so that's kind of our history with a lot of people here and a lot of experience, folks running the laboratory. So first of all, the objectives of this talk are to kind of go over what we do in the laboratory in terms of the exams that we do, what we do with Gait, in particular pediatric Gait, and give some background about abnormal pediatric Gait, and then go over some case examples, which hopefully might be the most illustrative part of this talk for this particular audience. We'll try to keep the technical stuff to a minimum. So the uses for Gait analysis are we divide them into a couple of categories, clinical and research. We're really here, we're a clinical Gait lab. There are certainly Gait labs around the country that are research only and some that are really focused on clinical aspects like we do. As far as the clinical work that we do here, we're trying to evaluate patients before they've had a treatment or before they're about to have a treatment. We call that diagnostic, but really we're not trying to pin a diagnosis on them. We already know when they come down if they have CP or something else. It's really trying to diagnose their movement disorders in order to aid the treatment plan. And then hopefully we'll see them back after they've had some kind of treatment, and then we can assess the outcomes of that treatment and maybe make even further treatment plans for the particular child. As far as research, kind of break that into a couple of different research categories. The most obvious is if we see kids who are having treatment A versus treatment B, or really even just a single treatment, we can look at the efficacy of that treatment by having objective data preoperatively and postoperatively to try to determine what works, how well it works, and maybe what doesn't work. I also use Gait to understand normal biomechanics as well as pathomechanics of Gait, so more basic science-y type stuff. And a recent thrust of some of our research has been to kind of use the data we've collected over the 20+ years we've been here and apply that to some current machine learning techniques to try to predict types of surgeries and outcomes. Patients that we see, you can kind of see here how we divide it up. Our biggest block, about 50%, is CP. We also see a lot of other neurological disorders, but a smattering of a whole lot of different diagnoses. So as far as treatment planning for the individual child, hopefully you can kind of understand by looking at really basic metrics that we do, we can objectively assess outcomes. So we're tying everything to numbers, and that's important in our world, especially with pediatrics, because a lot of the patients that we see in families, they've been through a lot with their kid under anesthesia, long recoveries. They want to believe that whatever we did to them helped them, right? So there's a certain bias involved. And then of course there's the other side of that bias too, with patients just think that whatever we did didn't help them. But we have numbers to kind of show what we did. And our main goal is to optimize treatment planning for the individual, whether that be surgery, bracing, or therapy, based upon the quantitative data that we have and using the literature that's available out there in the scientific world. And whether Gait is effective or not, there have been several studies to kind of show that it does have a significant impact on the patients that we see. Even at expert centers, so not just like community centers where they might be seeing a few of these kids, at centers like our own that see these kids day in and day out, they found that by doing a Gait analysis will change the surgical procedures that were originally planned in more than half the patients. And I'd say that's probably been our experience as well. At least half the patients we see, we end up changing something that was in the original plan for sure, either adding on or taking off different procedures. Another group, Frank Chang in Denver, they looked at a couple different groups, one that followed the surgery recommendations and another one that just didn't want to follow what the Gait analysis had to say. And they found that the ones that actually followed the treatment were more than 4 times likely to have a positive outcome. Tisha Ren in LA looked at the cost of Gait analysis, in case you're wondering about that. It's not exactly cheap, but it's probably cheaper than even having an MRI. But she found when you look at the costs added in compared to what the outcomes were down the road and the number of different procedures that kids had after gait analysis, that it really washed out. But if they had gait analysis, that was associated with having less things done further on. So we try to take care of like, using the gait lab stuff to have everything kind of done at once and less visits for surgeries or other treatments. And then our own group, we looked at hamstring lengthenings in particular, so a single surgery that we do a lot of or used to do a lot of. And we looked at if the doctors did those hamstring lengthenings when we actually recommended them versus kind of going rogue and when we didn't recommend them or just did them without a gait lab. And we found that when they followed our recommendations, again, kind of like the previous study, they were more than 4 times likely to have a positive outcome. Okay, so I'm going to turn it over to Amy at this point, and she's going to kind of go over all the different measurements that we do in the laboratory. Use the mouse.
All right, we're just switching here. So my name's Amy, and I'm a pediatric physical therapist that works here in the lab. So I primarily do the majority of the studies. Bruce is our helper with our engineering type stuff. So, you know, we generally, this is what a comprehensive gait analysis visit looks like. They can last anywhere from 1.5 hours to 2 hours. We take a pretty comprehensive history with the family as well as spending a lot of time looking at charts and doing chart reviews. We'll do a physical exam, and I'll go into some details about our physical exam, what we do for our outcome measures. And then Bruce will take over on the kind of the technical stuff of what we're looking at. So for the history, again, we do a comprehensive chart review, really focusing on their past medical history, their surgical history, if they've had Botox injections, and then really finding out what the parent and the child's concerns are and their changes in walking or function, their pain, and we collect goals using a goal attainment scale, which is really nice when they come for a follow-up. We present them back with their goals, and we have the family and the patient rate how they did on those goals. As far as our physical exam, I'm going to go into a little more detail here. We do anthropometrics, so your basic height, weight, calculate the BMI and the percentile, look at their leg length. When we do looking at alignment, so we do a video analysis, and at the end of the video analysis, we do a lot of standing pictures. And this is very important, as you can see here. This kid right here has a varus deformity, so it just gives us a nice visual look to compare what we're doing when we take our kinematic analysis. And you can see here, this girl looks a lot different when we have her point her feet forward versus having her point her knees forward. So we get a lot of information when we simply put kids in shorts and seeing what's happening. As far as our exam, our tabletop exam, we do a supine exam. A lot of different measures are collected, looking at the flexion of the hip, abduction, popliteal angles used to look at hamstring length. We do a Tardieu scale looking at whether the kid has an initial catch in their hamstring and a final catch, and that gets into some spasticity that we'll talk about in a minute. Whether they have a knee flexion contracture, Recker bottom, or again, the alignment of the leg on the tabletop. We looked at it in standing, but we also look at it when they're supine, and their tibial torsion, or if their feet are pointing in or out at the tibia. Then we look at them prone, so laying on their stomach. We look at knee flexion. We do something called an Ely's test that's looking at the spasticity of their rectus muscle. Their hip adduction, their femoral rotation is hip inward and outward rotation. And we also include a riders. That's again another measure for their femoral anteversion. And then their ankle dorsiflexion and another thigh foot angle, which also looks at the orientation of their tibia. We also do a pretty comprehensive foot exam, including the motions of the foot and what's happening non-weight bearing as well, assessing that. As far as strength goes, we typically do a combination of a manual muscle test, which is sort of a subjective measure. We've also employed the use of dynamometry, which you can see in this photograph right here. So they actually have to push against this myometer, which gives us strength in newtons. and we can compare it to our norms that we've had collected inside the lab. And of course, this is dependent on age. They got to be able to follow directions in order for us to collect this measure. So I alluded to how we assess tone. So we look at spasticity in a couple different ways. One's called a Tardieu scale, like I alluded to with the popliteal angle. We'll take this kid's leg and we'll move it, and we feel a catch in the beginning and then take them up to their maximum range. So that just gives us an indication that there's some spasticity going on. There's another assessment tool called the modified Ashworth scale. Of course, these are pretty subjective measures because maybe what I measure in tone is going to be different than a physician, but it gives us some idea of what's going on with their tone and spasticity. We have some kids that come with dystonia that we can use another rating scale. And then from the other spectrum, we have kids who are low toned or hypotonic, and we use a Baton score for that. In our lab, we've been for probably almost 10 years now looking at motor control using an assessment tool called the scale. And I'm just going to show a video here of what that looks like. Maybe. Oh, I got to get rid of the pointer. That's why you have a good engineer to help you out with this stuff. Here we go. So we simply want to see if they're able to isolate movements at the knee joint, the ankle, and the foot and the toes. So we ask them to go through these various ranges of motions of movements. So right here you can see she's dorsiflexing, attempting to dorsiflex, plantar flex, dorsiflex. And we're really looking, are they able to isolate that movement? Do they have movements at other joints in that leg, or mirrored movements on the other side of the leg? So we go through all of this and we typically videotape. So in this example, you can see she's trying to do inversion, eversion, and she's really using her whole leg or her knee to make that motion happen. Another aspect of our exam is looking at outcomes and their functional outcomes, and we do a number of things. We have parents fill out questionnaires. One of them is the Pediatric Outcome Data Collection Instrument, or the PODCI. We look at some Gait outcome measures. Again, these are filled out by the family, so they give their kid a score. This is our Gillette Functional Assessment Questionnaire. We have another one, the mobility scale. And for all kids that have cerebral palsy or some neurologic disorders, we look at their gross motor function using another scale. And we have various other smatterings of tests that we can use on other kids with other diagnoses, just to get a comprehensive look at what they're doing with their gross or fine motor skills. If we're concerned about endurance issues, we can do a 6-minute walk test. And in the lab, we do have the capability of doing oxygen consumption. All right, you ready? So Bruce is going to talk over. So after the physical exam is done, we'll do a video, and Bruce is going to go through the next steps that we utilize for the rest of the study.
Yeah. So one of the most important things that we do, and when I do talk to people in the community, I really emphasize this, is just take a good video of these kids. It's amazing what you can learn and see from their progression over the years with just a video analysis. So we
in shorts.
Yeah, and do it in shorts, yeah, and barefoot. So we do this for a number of reasons. First of all, because this is really how physicians are used to looking at kids, have them walk up and down the hall in clinic, okay? So we can present these graphs and charts that we'll get into eventually, but it helps to have the picture so they can relate what's going on. It also gives us information about things we aren't going to measure. For instance, we don't measure arm swing, but we end up making a lot of referrals to upper extremity people because of what we see on the video. Temporal measurements are just things like how fast they're walking, how they're achieving that walking velocity, support times. Those are nice functional measures that we report. Kinematics, this is kind of the bread and butter of how people think of gait analysis. We measure the joint motions, velocities and accelerations. And we do that by putting these retroflective markers that you can see on this particular patient. This is our standing trial, and these are just taped on the skin, and we collect data from 12 different cameras that look like that, kind of located around the room. And the idea is, at least if we can see at least one point with 2 cameras, we can figure out where it is in 3-dimensional space. We run that through a model that estimates the joint centers and then calculates angles based upon those joint centers. Here's just a quick introduction to what those graphs might look like for the knee here, shown on the bottom. We look at 3 planes of motion: the sagittal plane, where really if you're an efficient walker, all your motion should be; the coronal plane, frontal movements, and then transverse plane. In terms of kinematics, what we do is we think of it in terms of a kinematic chain. Our trunk and our pelvis are measured relative to the laboratory coordinate system, and then the hip is the femur relative to the pelvis, the knee is the tibia relative to the femur, and then the foot is the ankle is the foot relative to the tibia. We also look at kinetics, which we get by combining our kinematic data with our force plate data, kind of showed here in these butterfly profiles. And we look at those several different ways. We look at them in terms of moments and powers, as well as just the raw ground reaction forces. Joint moments are a product of the muscle force that's being applied across the joint and how far away from the joint center that muscle magnitude is. So you can see here for the ankle, we start out with initial contact, and then it just kind of grows steadily with stance. Joint powers are a product of that joint moment times the angular velocity. We talk about those as power being generated, concentric muscle firing versus power that's absorbed in eccentric muscle firing. Last kind of device thing that we use during gait is electromyography. We do a standard set of 10 muscles. This kind of just shows the raw data. These just get taped on over the muscle surface. We don't typically use fine wire, but we have the ability to do that in special cases if we have to. We take all that information, then once a week we sit down and go over all the cases, review them. The physical therapist who is in charge of the study writes up an initial report and then presents that to everybody. And our team includes orthopedic surgeons, physiatrists, other physical therapists, myself, biomechanical engineer, orthotists. And we come up with a list of all the problems that are going on, and then treatment recommendations for that individual child. And before we get into the cases, just a quick primer on, we're going to show a bunch of graphs along with the cases to kind of indicate what's going on. So a quick primer to orient you to those graphs. So this is just foot motion, dorsiflexion versus plantar flexion on the axis. We start out at initial contact, so whenever the foot hits the ground, we demarcate this one line here by where foot off occurs, so when the foot leaves the ground. And in between those two, we call that stance phase. And then between foot off and then the next initial contact, that is swing phase. And all our graphs will be typically reported as green and normal, as shown here. This is a normal band, 1 standard deviation. Left in blue and red and right, unless otherwise noted. Sometimes we do pre-op and left and post-op and right. So here is just kind of a list of different orthopedic things that we see in the laboratory. I won't bother to go over all these, but these are typical types of pathologies that we see. And we picked out a few for this particular talk that we thought might be of interest to this particular audience. So we'll look at one case of severe crouch gait, another of stiff knee gait, miserable malalignment of the lower extremities, and then an idiopathic toe walker. So our first case, and I apologize for the quality of the video. As you can see, this was done in 1997, so it's quite old now, but we hang on to this because you don't see these patients. We see some pretty severe patients, but nothing like this. This is kind of the natural history of cerebral palsy. This child had one operation, I believe, as he grew up in Mexico. But really almost no treatments until he was 14 years old, and you can really see some of the major contractions that he ended up with. Let me just play this video. So just kind of visually orient yourself to this. You can kind of see that his pelvis is kind of tipped back. His knees are severely crouched. But if you look, his feet are fairly plantigrade. The right foot is definitely plantigrade. The left foot comes close. Okay. And of course, on physical exam, this kid has a lot of things going on. Can't get his knees straight. issues. So what was recommended, he came down with a preoperative surgical plan of what we call a triple lever release. So they're going to kind of make all three of those major joints looser by lengthening the psoas muscles to get his hips in a better position, by lengthening the hamstrings to get his knees in a better position, and only if the left side was recommended a tendo-Achilles lengthening to get his ankle in a better position. Remember, that left ankle was the one that was slightly off the ground. So that was the preoperative plan. Here is his gait data. Again, so those things that we were looking at before, this is the pelvis. So we're looking at our typical here. Typically, the pelvis is about 12 degrees anteriorly tilted, and you can look at his left in blue, red in right. You can see quite a bit of posterior tilt in the pelvis. So he's leaning way back, and the reason he's doing that is because if he didn't lean back, he would fall over. Here's his hips. So his hips are very much flexed. He doesn't get anywhere near neutral flexion. Again, as shown in green, you should get into extension. Okay, so he's off about 30 degrees at the hips. His knees, I don't even know where they are. They're off the chart. Okay, if they're off the chart, we know they're bad. We don't have to know how bad they are. And then here is feet. So let's pay a little bit of special attention to these. So they recommended having a left TAL on him, but if you look at his left curve in blue here versus normal, it's pretty darn good. His right curve is in dorsiflexion, so excess dorsiflexion, because he's in so much crouch, his foot is bending more than it normally should, okay? So this left foot actually looks pretty good. So one of the things at the Gait laboratory, especially in its early days, was to kind of look comprehensively at everything that was going on. There was something in the orthopedic literature called the birthday syndrome, where someone like this would come in, not as severe, but they would say, oh, you know, your ankles are inclinus, so we're going to fix that. And then they'd come in and their knees were still bent. So, okay, well, lengthen your hamstrings. That worked, but then they were still tipped over the hips, so then they'd address that. So we try to take care of everything at once. Surgical recommendations based on the Gait lab information we just showed for him were, first of all, don't touch that left foot. It's fine. We agreed with doing a bilateral adductor release, the bilateral psoas release to get the hips in a better position, and a bilateral hamstring release to get the knees in a better position. And we also recommended, and we put it in red because it was not done, and what I'm going to show next, bilateral rectus transfers, which would have helped hopefully with his ability to get better swing phase knee kinematics. So here he is post-operatively, and I remember he was a super happy guy because just getting out of his crouch, he grew about 6 inches or maybe even more. So you can see he's much more upright. Still a lot of pathology there, but you have to consider where he started from. So you can kind of see his gait's not super smooth. We think the rectus transfers would have helped with that. But his feet now are both plantigrade. His knees are in a much straighter position. His pelvis isn't as tipped by visual appearance. If we look at his curves, we can kind of confirm what we're seeing visually. So now this is pre-post, pre in blue, post in red. You can kind of see his pelvis shifted up into, at least into the normal curves. Hips are still not normal, but we've made about 20 or so degrees of improvement. This is just the left side. We got the knee curve on the graph. And again, we didn't do anything to this left foot, but you can kind of see it started out functioning normally, and now with the knees in a better position, it is completely normal function. I would say if we did head lengthen that, then we would have seen excess dorsiflexion because we weakened him, and probably worse knee flexion. Same deal for the right side. Pelvis improved, hips improved, knee curve on the graph, but still not a lot of motion there. And this foot, remember, had hyperdorsiflexion. And again, we didn't do anything to this, but about getting his knees in a better position, it is now, again, functioning normally. Okay. This is our second case. This is a case of stiff knee gait. This child has right hemiplegia. Watch him walk. If we really focus on that right knee, you can kind of see how it doesn't bend, hardly at all. So what's going on here? This is where we can kind of use the gait analysis to really understand the pathomechanics that are happening. Your rectus femoris attaches at the pelvis. It's a 2-joint muscle. It attaches at the pelvis and the tibia, so it spans both the knee and the hip joint. Here are his preoperative knee flexion curves. You can kind of see where he wants to be. In green, here is the normal. If you look at his right side, his hemiparetic side, you can kind of see it is stuck in a crouched position and really doesn't bend. His left side is normal, but it is also crouched, but it gets a nice swing phase clearance. Okay, and the reason for that is just compensation, because you don't want one side to be crouched and the other side to be straight, or it'd be a lot worse appearing gait. So in this particular range is where the knee is flexing. If you look at the green curve, we've gone from full extension to full flexion and swing. What's happening with his rectus? Well, on the left side is normal side. If we look at that particular area, you kind of see the rectus is shut off and then starts to fire at the end to kind of slow the knee swing down. Okay. But if we look at his right side, it's just a mess. His right side is just on all the time. And if we look at that particular area, you kind of see a lot of firing when there should be no firing. And what is happening is that firing is not allowing his knee to bend during swing, okay, because the rectus is on. So what we do is we take the rectus and we kind of move it out of the way. So we know it no longer attaches in the front of the knee. We move it to an attachment on the side or behind the knee. That's called a rectus femoris transfer. You can see now post-op, he's got a nice swing on that right side, much smoother gait. If we look at his post-op curves, this is the right side, so his hemiparetic side. Started off where this is in blue, just kind of crouched and not moving. Post-operatively in the red curve after 98, it looks almost exactly normal. We saw him again 5 years later, and you can kind of see some reversion to the mean here, but not too bad. So he's not quite as good as he was originally after surgery, but he's still looking pretty good compared to where he was. And the left side didn't do anything to this, but remember, it started off crouched for compensation, and the left side basically corrected because the right side corrected without doing anything to it. Okay, third case is one of miserable alignment. I'm going to let Amy take you through this one.
Okay. Bruce is much taller than me. I'm feeling very tall in this chair. So this is another common diagnosis that we see and that pediatricians might commonly see in their office if kids come in with complaints of turning their feet in or turning their feet out. In this particular case, we've got this girl whose femurs are turned in, so femoral anteversion, and her lower legs, her tibias are pointed out. And again, I showed you that picture from the beginning of standing. This is why it's so important. We like to have kids stand with their knees forward and then their feet forward, because then we can really distinguish what's going on right here. And even on this picture right here on the right side, you can appreciate she almost looks like she has some genuvarum or bow-leggedness. And that's just an appearance of that. She doesn't have a true genuvarum. It's just the appearance since her knees are turned so far in and her feet are turned so far out. So what I like to say about this is usually we see these kids that if they're just wearing pants or a long skirt, a lot of the times their feet might walk with their feet forward because they're sort of canceling each other out. So that's why we really encourage, if there's any complaints of in-toeing or out-toeing, really putting a pair of shorts on and really watching these kids walk is very important. So she came in, oh, we should go back and show the oh, we don't have a video. Do we not have a video? Oh, the video is coming. All right. So in here, we're looking at her gait curves and hip rotation. And right here, you can see this is actually excessive inward hip rotation. Here we go. Oh. Oh, hang on. There we go.
Yeah, that might not be showing on there.
Let's see. How about, can we move it here?
No.
Hang on. Hold for technical difficulties on this video.
Oh,
Here, you want to sit?
Where's Zoom? See Zoom? No, it's all right. I don't know how to change it, the screen. Well, might have to just.
So Bruce, is your video embedded in your PowerPoint, or is it?
Yeah, no, it's playing outside of it, and I'm trying to switch the screen.
Okay.
So, oh, stop share. Here we go. Let's do this.
That's
Stop share, and now I can do share, screen 3. So that should work. Yep. Where'd that video go? Actual. Let's just try playing one now. Where'd she go? There it is.
There we go. Can you see that?
We don't see it quite yet. No, you'd want to. So yeah, if you did your stop share, you go ahead. You might go ahead and reshare your screen and tell it to share your internet browser or whatever program your video is on. We're doing okay on time. We're okay to wait for a minute and figure this one out.
Yeah, and while Bruce is working on it, I can keep talking through it, because the other thing that we do that's really nice is we put some stickers on just like the center of their patellas or their kneecaps. And I think this is also very helpful if you ever wanted to take a video when you're in your office, just to put it, you can even use like a marker or something like that to just draw a little circle or something and then watch them walk, and you can really appreciate what's happening with the rotation at their knees. And so you can imagine with this girl, like I said again, if she just had pants on or a skirt, and you probably wouldn't even notice that she had anything going wrong with her alignments, because it sort of covers it up and masks everything.
There we go.
Okay, we're getting close, and we'll show you the video here, and you can see how important it is when we put those little stickers just to visually see what's happening with her knees.
3. Where the hell is it? All right, let's play it. Okay.
Looks
So
good.
it's still not showing?
No, it looks good. We see it.
Oh, okay.
Oh, good. All right. Okay. All right. So you can really see, with those knee stickers, her knees or her thighs turning inward, and her feet actually look pretty neutral in that video right there. But again, here I'll rotate back here, because I think this is a pretty common thing that I think may present to your office. Kids commonly with this disorder complain a lot of knee pain. So we see a lot of complaints of knee pain with these kids.
Yeah, just go ahead. Just close it, and then they should still be able to see that PowerPoint.
Okay. We're gonna move on. Make sure. Do you guys see the next slide?
Yeah, it looks good.
Okay, great. So so she went on and had a pre-gait lab, and then she underwent rotational osteotomy. So quite a big surgery, because they not only had to rotate her femurs, but they also had to rotate her tibias. Because I think it's really important to point this out, and I'm just going to go back to her standing pictures. If they only rotated her femurs, you can see already she's pointed inward with her femurs. If they only did that, rotated them outward, her feet would be really excessively outward. And so it was really important that she come in so we can distinguish that she's got both things going on. You have to take care of both things, or else we're going to just cause another problem. And usually in our facility, they would go on to just do one side. So they'll usually do the femur and the tibia on one side, and maybe 6 months later go and do the other side. So it's a stage procedure. It's a pretty big hit, but this girl showed some significant improvements. Pre is in blue, and post-op is in red, and green, of course, is normal. So you can see a nice significant improvement in her her inward rotation of the hip. Uh-oh, let's see if this plays. All right, and then here we are seeing her post-operatively. We'll watch her come back towards us, and you can see a nice significant improvement in her alignment, with her knees now pointing forward, and her foot progression, or how her feet are pointing, are now more in a neutral position. So very nice outcome. So the next one, I think that is another common one that presents to pediatricians, and we get a number of referrals, is our kind of standard idiopathic toe walking, kids that are walking on their toes for no reason. And oh, the audio's on that. So usually with these kids, it's so important to do a really good comprehensive history for us, just to make sure we don't have anything else neurologic going on. Sometimes we do send these kids on for a neurology appointment, just to make sure that they do have the proper diagnosis of idiopathic toe walking. You can see in her case that she's really high up on her toes, and we don't have her exam measures here, but I could almost guarantee that she was contracted probably at least 20 degrees in Aquinas. So in looking at her gait stuff, right here, left is blue and right is red. And you can see in that ankle curve right here that she's in, here's our normal, she's in a significant Aquinas, right more than left. Continue on with the space button. And then we also see in these kids that are really tight in Aquinas that they have an early plantar flexion moment. So looking at our moments, and a power absorption at loading, and decreased power when they go to push off before swing phase. In her case, she was so tight, again, that's a two-jointed muscle, so it's attaching from the foot and then behind the femur. So she was actually hyperextending or having some recurvatum at her knee, and we're able to see that on these curves as well. And that also impacted her knee flexion moment. So she had quite a number of things going on here impacting her gait. So she went on to have a surgery where they just lengthened the gastrocnemius muscle. So that was bilaterally, and here she is post-operatively. You can see that she's definitely out of her Aquinas and more flat-footed. And again, we're looking at pre and post. Pre is in the blue and post is in the red, and green is normal. And now we've got almost completely normalization. Oh, we're spinning these fancy arrows of her Aquinas. And this also improved her plantar flexion moment and her power absorption, and the push off at her power at push off. You can also see here a change in her knee recurvatum and also in that knee moment. So pretty significant improvement here with our idiopathic toe walker. So that's it. We've left plenty of time for any questions. If anybody has any questions, wants to unmute and ask us anything, please go ahead, and I'll be happy to try to answer all that. Here, I'll let you take control. No questions, huh?
So as we wait questions, I will say to everybody who's involved here, I mean, again, thank you to Bruce and Amy for this presentation. And we do have time for questions. You can simply unmute your microphone and speak up and be part of the conversation. You can also use a little chat feature. And unlike last spring, we were doing this, but now we're all far too familiar with Zoom. But you know that you can ask a question here in the chat feature. And if you're feeling a little bashful, we'll be glad to read those over, and our experts will answer those questions. And as we wait questions, I do have one. I mean, Bruce and Amy, we have providers from all over the region, in 6 Western United States and everywhere within Utah. And they're very familiar with Shriners, but they may be less familiar with, you know, with the to-dos and logistics of getting a patient into your program. Talk a little bit about that. If there are a need for a referral, do they go through the Shriners website? Should they contact you directly? What's your preferred method for communicating with these providers?
Yeah, we have our own kind of referral form, but in order for the patient to come see us, they have to be seen by a clinician here first. We've kind of set up a process to make that really easy. In order to get in the door, the first step is to really just call the hospital. Is that right? And
Yeah.
I'm not even familiar with if there's an online process. But as long as a doctor has referred the patient to Shriners, the patient's family just needs to call and set up an appointment. And then they'll become a Shrine patient. A clinician will see them before they have a Gait lab. If they already, like, you know, if the provider has filled out a Gait referral form, then that can all happen the same day.
You'll get the referral number.
Yeah, and
Yeah.
he's going to get the referral
I'll put
number.
the referral number in the chat box and everybody can write it down. And again, the provider can refer them, but the families can also self-refer and just basically call up too. So, but it definitely, I think, helps to have a provider send over a note what the issues are. If it's, like, toe walking, or if it's in towing, out towing, that kind of thing, or you're worried about hip pain, knee pain, or something like that.
Yeah. So there was a question about insurance. There's one before that. Hang on. I'll send a short video. Oh, absolutely. Yeah. If you have a video of a patient that you're wondering if they're appropriate referral, yeah, absolutely. We don't really have a great way to do that. I would just, in terms of other outside of email, but you can certainly email me or Amy or somebody with that. We would be happy to take a look at that and try to figure out what's going on and whether we can help them or not. That'd be awesome. Cost of the exam.
Sorry, Bruce.
Sorry, go ahead.
So yeah, so on that note, as far as emailing you a video or a link or whatnot, after this meeting, I will send an email to all 30 participants with information about claiming CME and such. Can I give your email address to these 30 clinicians on this call?
Please do. Please do.
Okay. Thank you.
And of course, but the only thing with the emailing and the stuff is just the privacy stuff. As long as you handle the privacy on your end, then we're good here. As far as the cost, Amy, do you even know what the bill is at this point?
I think it's well over like $1,000.
Yeah, I was going to say about $1,500.
Probably,
And
yeah.
It's pretty typical that insurance will not pay for this, unfortunately. It was one of the things we've been butting our heads against the wall for over 20 years. For certain insurance companies, for children who have cerebral palsy, it will be paid for. In fact, one of the best payments providers that will pay for it is actually Medicare, right?
Medicaid,
yeah. But outside of CP, it's commonly not reimbursed. That being said, Shriners. How do we politically say that? Shriners accepts kids without insurance, accepts kids with insurance, and kind of treat them the same way. You guys probably know more about this than I do, but your insurance that you carry is a contract between you and your insurance carrier, so we are obligated to drop that bill.
We're obligated to bill.
We're obligated to bill. Let's just leave it at that.
Yes.
We are obligated to bill. Whether you pay that bill or not, or the families pay that bill or not, is up to them. Yeah.
Yes. No. Nobody should. There should not be any financial barriers to coming to see us, and we've never had an issue with. Yeah.
And we have finance people here who meet with patients all the time to kind of go over that, and they'd be much more qualified to say how they handle that than we are. So if there's any need, we're very generous. Let's just put it that way.
And I think that goes to say, if you have any kid with orthopedic issues, that the families may have insurance, but insurance copays are very high, or other issues like that, like really having problems with being underinsured. They're a perfect place to send.
Oh, no, I didn't see it for the next one. Oh, that was just your.
Okay.
Okay, well, it is 10 minutes to, and we've had quite a few questions. So we'll keep the line open here for additional questions as we take our few minutes to wrap up. But we're just so pleased to see everybody here back at our first Pediatrics Echo of the fall season. And again, we'll have more sessions coming up. Watch your email, watch our website. We'll get the schedule out there. It's kind of fluid right now. COVID has thrown everything out of whack for us, as for all of you. And we're working on finalizing the schedule, but it's coming. So keep a close eye on your email. Real quickly, I want to make sure that everybody who joins us gets CME information today. And there are multiple new people who I don't recognize. So to you, welcome. Pay attention real quick. If you're any of the following users, you need to email me if you want CME information or nursing contact hours. If you're showing up here in Zoom as either Amber Perry, H. Harris, iPhone, Jake Penrose, James Knuckstedt, Jay Peterson, or Margaret Conklin, any of those, please email me here to get your CME information, and we'll take care of things from there. And otherwise, I think we're at 10 minutes too, and the questions have ceased to come in. Bruce, Amy, any final thoughts?
I don't think we have anything else. We're here to help, so please, even if you want to email Bruce questions or us, we're happy to help and field questions and patient referrals.
Yeah, absolutely. Yeah, we try to accommodate the patient schedules. We know people are coming.
Okay, great. Well, thank you.
So we have a day or two. We get our kids to stay overnight if they need to. So keep that in mind.
Okay, well, that's a fantastic presentation. So, on behalf of the ECHO team and Dr. Liu and Dr. Sandweiss, who couldn't make it today, thank you to our friends at Shriners Hospital for taking time to teach us about their expertise and about these important treatment methods for these pediatric patients. And with that, we'll give you back a few minutes of your day, and thank you once again for coming. Watch for my email if you have questions, if you need CME, and I'll be glad to put you in touch with these fine clinicians for further information. Thanks, everyone.
Right, thank you.
Thank you.
Take care.